I'm Amy Wagner. I am a psychologist at the Portland VA currently, and I'm going to be talking to you about applications of DBT to trauma-related problems. They're videotaping this presentation, just so you know, for anyone who's going to be asking questions. It's for use by ISTSS, but it means I'm kind of restricted to my space, so I can't be as dramatic as I normally would not be. So I'm going to stand here mostly. When we do ask questions, it would be helpful if you could come to the microphone, or I'll do my best to repeat your question when you ask. Okay. I also am going to try to keep this pretty timely. I think there's other things in here, perhaps after us, but probably more relevant to me. I have to check out by before noon. Probably some of you do too. So we'll try to leave a few minutes at the end for questions, and I'll have to leave pretty quickly at 11:45. Okay. So it's really interesting for me to be here talking on this topic. This is actually a topic I've presented on for years. I was going back through old notes as I was preparing this talk, and I first gave a presentation like this at ISTSS in 2003, and it's kind of amazing to realize how fast time goes by. And recently, I have a long-standing history with DBT. Marcia Linehan was my academic advisor in graduate school. I've used DBT in my work at the Boston VA and at the University of Washington when I was there in psychiatry. It's always been a piece of my life, but most recently, in 7 years now, I've been at the Portland VA working in a PTSD clinic. So I'm a clinician and a researcher doing evidence-based practices for PTSD. And are many of you VA practitioners? Some of you? Okay. So all the rollouts with prolonged exposure and cognitive processing therapy. That's a lot of what we're doing if you work in a specialized PTSD clinic like I do. But we also know is that a lot of people aren't getting these treatments, even within our specialized clinics, for lots of reasons. And one of the primary reasons is the complexity of the patients that we see. So even when PTSD is a primary diagnosis, there can be all kinds of life circumstances and personal difficulties that make engaging in those treatments hard. So I've recently had a strong interest in trying to take different parts of my life and meld them together by integrating more DBT in the work that I do. And so and our clinic is just starting to shift that way a little bit. So some of what I'm going to be talking about are thoughts that I've had for many years. Some of these are new thoughts as I'm considering how this might fit within a VA setting. And then I'm going to be presenting some neat new integrated treatments that are coming out of the University of Washington. So I have lofty goals because I know the time is going to go very fast. So this was advertised as an introductory level workshop, and I just know from lots of times doing workshops that probably means that there are people here from all different backgrounds and levels of familiarity with DBT. And I doubt in this day and age there are many people who have no experience with DBT, but let me just ask, is there anyone who's really just brand new to DBT? This really hasn't been anything that you've been exposed to in much detail. Okay. How many of you feel moderately comfortable with the general structure and principles of DBT? Okay. And anyone who feels like, yeah, you got it, and it's going to be kind of hard to sit through anything? Okay. That's really brief, rudimentary. Okay, so I'm going to do a very brief introduction, but really trying to tailor that as much as possible to how this is relevant to working with people with trauma histories. And then we'll do a little bit of practice with case formulation and discussing how the principles of DBT can be useful for case formulation of our more complex patients with trauma histories. So trying to make it as hands-on as possible. And then one of my areas of interest over the years has been treatment of dissociative behavior in particular. So as much as we have time, we'll talk about some applications for DBT for that particular problem. And then, as I mentioned, there's some neat new approaches that integrate DBT, in particular with prolonged exposure therapies. I just want to tell you what's happening in that area before we finish up. Anything else you're really hoping you'd get out of this that you came here thinking, that's what we're going to do? All right. So just to set the stage of why we'd be having this conversation in the first place about applications of DBT to trauma-related problems, kind of what I was alluding to at the very beginning. We have some very well-established treatments for PTSD, in particular prolonged exposure, cognitive processing therapy, EMDR, but we also know as many people are not getting these treatments. Doug Zatzik, a colleague of mine, uses the term REACH to explain how of the population of people who could really benefit from these treatments, only a small proportion are actually getting them, and there's a bazillion reasons for that. But one of the reasons is that people with really complex presentations often, before I get on to research, many of us who do this kind of work as clinicians feel like people with very complex presentations have more urgent needs, more perhaps life-threatening conditions where it wouldn't be clinically recommended to be moving into trauma processing therapy. People, as I said before, with really complex presentations may have so much life chaos that actually engaging in treatments can be difficult. And then we all know, too, as providers, we're often nervous, like, would this be helpful? Would it make things worse if I went in this direction? If we were just going to be guided by the research, most of our treatment outcome studies for trauma processing therapies have excluded people with more severe presentations. We're not entirely sure how effective they would be. And from my perspective, what's really critical is why you'd be, your case formulation, what would be guiding you to choose the treatment you were doing. Treatments like prolonged exposure and cognitive processing therapy are based on a very specific case formulation theory of why the individual has PTSD, either a conditioning theory, emotion processing theory, cognitive theory that would explain the presentation of the problems that you see. People with very complex presentations may not fit within that specific case formulation, and therefore we would need a different kind of treatment that does take into account the various problems. And then we have few well-established treatments for that large, wide breadth of problems that people with more complex histories present with. So then we're often left, with the question, what's a clinician to do? There was a recent Journal of Traumatic Stress, what do you call it? It's not episode, it's not edition, volume, where there was a lot of articles on complex PTSD and the controversies surrounding that diagnosis. Patty Resick had a diagram, which I pulled, and I know it's blurry, it's hard to read what's here, but I decided to keep it because the blurriness helps make the point I actually wanted to make, which is that what this shows, what can you see? So it outlines the overlap in symptom presentation of some of our major diagnostic categories that are often associated with people who have very severe histories of prolonged abuse. We've got PTSD, we have borderline personality disorder, major depressive disorder. In the middle is the constellation of problems that are frequently linked with complex PTSD, even though that is a bit controversial. A lot of differences in opinions of what should all follow under that category. And so given the overlap, one of the questions has been, do we need a new diagnostic category? But from my perspective in terms of what we're doing today, the question is, what does this tell us in terms of what treatment would be most effective? So dialectical behavior therapy is a treatment that I think does have some promise, given that it's designed originally for people who would meet criteria for borderline personality disorder, and Marcia Linehan has expanded how she defines who this would be appropriate for as to the multi-problemed client with severe emotion dysregulation, in which the problems that they present with can be understood as related in some way to severe emotion dysregulation. So DBT, as most of you, since most of you are aware of DBT, are aware, targets a wide range of problems, and those problems, as you saw in the diagram, often overlap with PTSD and with the presentations of people who have more complex traumatic experiences in their history. DBT is based on empirically supported principles and interventions, in particular